Welcome to another EMCT-sponsored podcast on the topic of onboarding in emergency medicine, where we're recognizing groups and organizations that have raised the bar on an educational and training standard for providers to work in the emergency department if they are not residency trained in emergency medicine. The American College of Emergency Physicians in 2019 commissioned a task force to look into improving rural care. This Rural Task Force released its summary in 2020, and within that report was one health system that was found to do a particularly good job and, in fact, be a model of best practice for onboarding in emergency medicine, particularly onboarding at low-volume, frontier critical access hospitals. That system is the Mayo Health System. And joining us today is Dr. Susan Cullinan. Let's join that discussion now.
This is Steve Jamison again. We're doing another EMCT podcast on onboarding in emergency medicine with a focus on rural emergency medicine. I want to invite our guest, Sue Cullinan, a physician from the Mayo system. Hello, Sue.
Hi, thank you. Thank you for having me.
Yeah. So can you tell me what your role is at the Mayo system currently?
Currently, I am the community chair for emergency medicine. So the 19 hospitals that surround Rochester in the Midwest, both Minnesota and Wisconsin, the community chair, and also specifically in Northwest Wisconsin, Eau Claire, and the surrounding critical access hospitals, I'm that regional chair also.
Excellent. So we've chatted a little bit about onboarding and education and all, and I have a little experience with the Mayo system, having helped up there years ago. But I want to get a sense, because Mayo of what your system is now and kind of the journey to get there, because you might not know, but Mayo has been a bit ahead of the curve and been recognized by our ACEP Rural Taskforce as a model of best practice for onboarding when we were looking for guidance of how to onboard non-EM trained physicians, PAs, and NPs to emergency medicine. And so we went looking for, again, models of best practice, and is there anyone out there doing it right? And so a lot of the recommendations that came from the 2020 Rural Task Force came because of looking at the model that's there. And just to recap, and we've gone over this with our listeners before, but there were 5 tenets or pillars to that. And 1 was foundational training, 2 airway training, 3 was simulation, team-based training, 4 was time in a high-volume facility, and 5 was tele-emergency medicine and having medical directorship at those facilities to make sure that all levels of, or all 5 of the tenets were covered. And we felt that would provide quality emergency care. And we were tasked with this as a rural task force because there were many rural hospital closures due to financial constraints, and there was less than optimal care of patients in those facilities. And so we wanted to find out, what's the special sauce, or what is it, what is it you do that for onboarding? And so I guess my question to you is, what was the epiphany, or what was the journey where you had to decide as an organization to change? And as you acquired some of these, low volume facilities in the rural area around the Mayo system and around Rochester particularly, and into Wisconsin, how did you come up with this need, or how was it discovered? I mean, did it just pretty much right in the face, like, oh my gosh, this needs a change, or was it over time?
I think it started over time, and I'm not going to take credit for it at all. Dr. Boyning, Alex Boyning, was, just instrumental in getting this started with the training and the boot camps and the skills days and everything in the past. So he was part of the training in the whole health system for years. It's changed. It keeps continuing to change. Boot camps change. We now have an EM fellowship for our APPs that are interested in emergency medicine. We still do a lot of training at the different sites with the boot camps, and that kind of varies depending on how much experience when you hire an APP. They're all required to do airway training, the skills day training. They all are part of our group. So in our Northwest Wisconsin group, for instance, they work in high volume EDs and they work in critical access hospitals. And they don't work in a critical access hospital until they've had experience in training and had, been doing some of this on their own and working with physicians and doing these different courses. So we feel that they're confident and safe and really willing and ready to go out to the critical access sites. So I'm just thinking of the 5 you listed. We have telemedicine, so they call in, and talk to telemedicine and get virtual assistance for all our ESI ones, the codes, the traumas. So they have assistance, so they're not alone. We have an ED MOD officer of the day in Northwest Wisconsin, in Wisconsin, that also can assist them with questions if they have questions just on, run-of-the-mill patients, or helping decide how to manage or work up a patient. So I think they have assistance at some of the sites. And other sites, we have physicians at some of the at the critical access site, the larger ones, that also they can ask questions and bounce things. But this has been an evolution over time, right? So it's nothing, we keep on changing. Now we're trying to institute the ACEP guidelines where we do more supervision, and we're just starting that whole process. So I look at it as a collaboration, and I say that word and it's like, I know it says supervision in the ACEP guidelines, but it's really, discussing the patient, talking to the APP about the patient, and determining the best course or action. We have some really well-trained APPs, and this is not going to be a tough job. This is going to be just a great collaboration to pick the best care for this patient, and then what's the next steps, where do they go? So more of evolution, and it's still changing.
No, it's been a journey for everyone, and there are a lot of health systems, a lot of physician groups, small and large, dealing with this issue and taking over new contracts and trying to work out the training. We all would like to just hire in trained APPs at low volume facilities so they can go there, but clearly that training varies, and they may come from different backgrounds. They may have been an orthopedic assistant,
right,
or in cardiology, and have tremendous skills in those areas. Paramedics that make some of the best, that go to PA school and do emergency medicine, terrific at doing procedural things and feel comfortable and are competent doing airway and acute resuscitations. But then we find that they've got knowledge gaps in other areas. And we give an example in one of our, few examples in some of ours with, someone who misread a wide complex tachycardia as, AFib, and it was, someone in VTAC that needed to actually be cardioverted, and, a Miss-Brugada syndrome and things that, you got some that are,
right.
You don't know what you don't know. And I know people hate to hear that or say that, but there's truth to that. And you need to have more than what the current standard is at most critical access hospitals. We found in the Rural Taskforce, when we surveyed a large number of different listservs through PANP organizations and the CALS organization and all, that the current standard is to work in a rural emergency department is ACLS, ATLS, and PALS. And then your license, and suddenly you're an emergency provider. And we all, said, well, this is crazy. And even PANP organizations, SEMPA and AAENP, recognize, oh, that's crazy. And so you look at that and you've got everyone in agreement, and then you say, well, okay, let's change it. And then you have organizations like Mayo that really took the ball and ran with it. And I'm sure it was a process to develop, all of these training programs and what was mandatory to finally work in those low volume facilities. And then you had the development of your postgraduate program for APPs, which is 18 months, I believe, that they go through, and that's becoming more of a standard to work in rural, I understand, which is terrific. But the biggest barrier that I hear from health systems or from physician groups is time spent at a high volume facility, which is absolutely critical
It is.
to work
Yeah.
alongside emergency medicine trained boarded physicians. Can you just speak to that component of it, and how did you justify that through your Mayo system?
No, it's part of the whole process, because if you don't see the volume, you're not going to get comfortable. And you know that even as a physician, you can go
Right.
months and not have a chest tube, and all of a sudden you're just like a little rusty putting it in, and you're like, wow,
Right.
I haven't done one of these for a while, or see a certain type of patient. So I think it's critical that they work in the high volume facility and see patients and do procedures. And then it's also nice because you're working, they're working side by side with us. And so you get a feel for them. So then when they are, years down the road, maybe at a critical access site, you know them, they know you have this comfort level. I just think that is so important. And we do, you have to take the time to put that in there. You have to take the time to set this up. Like I said, Dr. Boyning did this in the past, set all this training up. And now it's just, there's a pod that they're in the emergency department with, they're with the doc. That type of taking the time to set that up, you just have to do it. And they have a bridge to solo practice. So before they go out to what we call solo, even though I look at it, they're never really alone. They have,
Right.
tele-EM, they can call us. I think they have a lot more resources than they had before, and I want them to use it, right? You don't want anyone to feel alone or stuck or have a really sick patient that they can't get out of the emergency department. And that's why we're trying to really work with them, with our MOD person on call, so that this MOD is aware of all 5 sites or 7 sites, whatever they have. So you're not just focused on your hub site, because you can't focus on the hub. You have to look at it as, we look at it as 5 doors, 7 doors with one big hospital in between. And so I think that's important, but you have to take the time to do that. And we've had, like I said, some great leaders before me that set this up, and we are continuing to do it and move it forward. It's going to take a little time, but I think you get the best APPs out of that have experience, and that they can do different leadership, they can do different skills days, they can do ultrasound training. And that makes them want to stay in the practice longer too. They're not
Right.
looking to go out if they're doing things they love.
Yeah. Well, and a couple of really good points. One is retention is a big deal. And there's so much turnover in rural. And if you look at onboarding in any industry, they'll tell you that it is so expensive to re-onboard. And the cost, for APP has got to be over $250,000 to finally get them trained, and probably even more through the Mayo system. And you don't want to lose that individual.
Right.
You want that, you need that coverage out there, and to go through that process again is really painful. So doing a proper onboarding process can really save an institution in the end.
Right.
The other point I was going to make was when they come and work at your higher volume facility and you get to know them, you're on a first name basis when they call, and instead of not knowing what that interaction is going to be as the person making the call, and you're nervous and you don't know how to sell it and all, or because if you don't know what's really going on, but you just know the patient is sick, it can be very nerve-wracking, and who hasn't gone through that, in their earlier career, having to sell it an admission to internal medicine.
Oh, exactly. Right. Which
I
group?
still have one last week, it's like, I don't know why I've turned over every stone. I don't know why this.
And we all ask for help. So I don't want them not to. I want them to ask for help. And I just think you got to have the resources in place for that to take place. And then you also have to be willing to take those questions. So we would have our ED docs who are on shift take those questions, but often they're inundated with patients. And so then the conversation become a little shorter because you don't have the time. So I think having this ED MOD role, the medical officer of the day role, that has the time virtually, and they can even zoom in if they want to see the patient, or they can just have that phone call. I think that's important, time set aside to do that. And they're also managing, they can look at the boards of the different EDs and they can call in and say, hey, you're swamped. Can I help in some way? We are setting up some virtual, can I see a patient for you type thing. We haven't started that yet, but that's part of our next steps to assist them. If they're the only provider at a small site that's got 20 in the waiting room, the ebbs and the flows, can we help in some way from a virtual standpoint to even see a few patients for them and offload their back end so they can take care of the critical patients? So But being there to be available for those questions and helping them, and maybe even placing the patient, that's another part. They can spend hours on the phone trying to find a bed. And this medical officer of the day has been doing a lot with that. Like, let me help you find the bed. You go see your next patient. I'll take care of getting this patient transferred to a higher level of care that they need. So we've been doing a lot of that too, which helps them in the long run.
Well, and I imagine during COVID and during bad weather times, they're holding patients for longer than they would like. And having that support through telemedicine, whether it's the emergency physician or then the admitting physician, if they're having to stay at that facility, it has to be just a tremendous help for them to get out of foreign areas or be able to manage or, through areas.
Well, right. And none of us are really good at inpatient care.
No.
We've noticed that with the boarding, we have our hospitalists that manage our patients in the ED if they're boarding for a short period of time, and they're doing the best care, because I'm not trained in that. And so I can't expect an APP to do that any more than, any of us. We're not trained. So I think, I totally agree. I think having that support and that help, but we didn't get there overnight. I mean, you just have to, I think for anyone starting this, you just got to get someone that's willing and wanting to train and get this set up and start going. Because if you start today, by next year, you'll be that much farther ahead. And,
well, I'm sure that there are budgeting issues as well that you have to put on annual budgets, that we're going to have this number of people start in, and they're going to have to spend X amount of time at, in Mankato or wherever else that you're at.
Higher volume. We get that too, right?
Yeah.
You have to have training sites and, educational shifts. And we have a PA program in Rochester that it's not just specifically ED, but the PA programs for all PAs. And they come through Eau Claire and La Crosse and Mankato and Austin, Albert Lee, and they do shifts. And same with the fellowship, they'll come and work shifts. And when they get done, they just have so much more experience, especially the fellowship. I mean, they are well trained. Yeah, we just really respect that too and appreciate it.
Yeah.
And yes, we always want them to stay, but I know they can move and they can go. And, we're not beyond that too. People leave and, that cost, we're aware of that. And, I wish I had the answer for that. I really don't.
Well, I mean, I guess part of it is loan payback, that sort of thing, where, if they leave, they have to assume their loan again, that sort of thing. There are different incentives you can have to attract them and all. And I wouldn't say put handcuffs, but it is a bit, I mean, it's a financial incentive for them to stay as well. So, because if it's a minor financial incentive to go somewhere else, that's tragic,
But I think the best thing is making the job enjoyable for them and making it to be where, there's a lot of APPs that want to be just really solo and independent. And I think even the supervision policy, the guidelines that came up through ACEP, some people are really concerned about it. And we're just starting that now later this year. And we're going to see, how it works. But I really want it to be, like I said, a collaboration where it's more of a discussion on the patient. We see them, we kind of formulate a plan together, and you move on. It's not taking away anyone's thoughts or, I still want them to see the patients. I still want them to do the procedures. We still want to work together as a team.
Yeah.
You have to.
Well, and I'll speak to the supervision part of it and seeing every patient, just because I think there's a bit of hypocrisy to say that every patient in rural needs to be seen by an emergency medicine trained boarded physician, when we know at high volume facilities, when the PA or NP is working there are many patients that get seen, kidney stone, they have a, distal uteral calculus, they've given them pain meds, they're not febrile, they've worked out follow-up, and that patient is gone. And that's a pretty moderately complex, not to mention the number of lacerations and minor upper respiratory illnesses and that sort of thing that you won't even hear boo about, not even see a CT or see anything come through. And I challenged ACEP with that, because it really is developing a different standard, because I was on a task force to help write some recommendations for conversion of critical access hospitals or rural emergency hospitals, send it to CMS. And we started to develop a standard that was greater than the current critical access hospital standard for conditions of participation. If you're going to have, a physician see every patient, and no one will make that conversion if that were the case. And it's not realistic.
we certainly like the indirect, where you just have a conversation like, oh, I see the workup on the kidney stone. Fine. I mean, I don't need to see every patient. I totally agree with you on that. But I think being aware of every patient in your ED with them, I think that's doable and attainable and probably should. Is that kidney stone getting the CT, or are they just, well, he's had stones before, but he's 70. Do we need to check his aorta? He hasn't has, there's those conversations that are great to have, and I think make a joint decision and go from there. So I agree with you. I don't think we need to see everyone, but I think we have to be aware of everybody.
And that's a terrific distinction, because in my previous group, not throw anybody under the bus, but when I was medical director, I made sure that there was a physician assigned to every patient. So you knew who was responsible for that APP and that patient. APPs would sign up for patients themselves, but an emergency physician got assigned to every patient.
Yeah. So
it was your responsibility to work with that APP on that particular patient. Now, if that patient came and went and you have that relationship with that APP and you didn't hear boo about it, okay, then and we had many that had essentially done 10 and 12 or more year fellowships with us because they really wanted to do everything. And these are friends, you're working with them, and it's just another colleague.
Right.
And they would be like, really, you want to hear about this guy just sewed his thumb up or whatever. So you just don't have those conversations in reality. And that's just true. What happened, though, from there, because of that casual relationship, new physicians that were graduating were like, if I'm not seeing the patient, I don't want my name on it. No way. And so we went away from that and went to a system where the APP was just another colleague in the department. And now there was no accountability, no supervision at all. And that's where I think many, many physician groups have gone. And is that the right approach? And so that's way in the opposite direction of
I think we've gone both ways, right? And we did the exact same thing. And so I think now we know that we are responsible and we have to see these patients, or at least hear about them and know. And it really depends on, and this too, it depends on the skill level and how experienced your APP is. There's going to be new ones coming out. I mean, they're all the time. There's new APPs, and some of them have a lot of skills, and others, you've had as a friend and a colleague for 10 years. You still need to know about the patient, but you need to know less, and you just, it's a lot less. You can review it and be good, or you can pop in and say, meet the patient and talk to them and examine them and say, yes, I agree with your care if you're concerned. But if, just talking about the patient is maybe all you need, especially for somebody with experience. But there's a variety. There's such a wide variety. But I totally agree with you. We went almost too much one way. Now I think we just have to bring it back to the middle. And again, it's that collaboration. People hate that word sometimes, but I think it's a good word.
But running the board is important, going down your pool of patients. And you're right, let's be realistic about what that supervision is going to be, but let's not make it zero.
And I've had APPs thank me for this, because they feel like before they just couldn't get a word in, or they couldn't talk to the doc because they were so busy seeing their own that they couldn't get the help they needed. And it can be worrisome, and I totally feel for that. So I think this is important for those that actually want it too. And yeah, they're great colleagues. I don't mind doing this at all. I think this will be beneficial. So
yeah, and I'm not sure how you track production and things within the Mayo system, but many systems, including where I'm now, it's RVU system, and it cuts into your RVUs unless you get a portion of that APP's RVU. And that's what we had to do with our previous group as well, as 25% of the RVU that the APP was generating. Whatever system you put in place, you need to have some financial incentive as well for that doc to at least be involved in that for some of these groups, because otherwise it's just a burden. It's like, I'm not going to work with APPs, period, because it cuts into your production, and they just want to focus on what they're doing, and it can produce some animosity. And we found that when we would, have new docs come in that hadn't worked with APPs and they're in the residency, and they're really getting their legs under them as well. The last thing they need to do is worry about someone else's patients and then come in mid workup and go, oh my God, now where am I going to go? So
Right. Yeah, it is harder for the newer docs too, and because they don't know them, like you said, but after even one shift, you feel more comfortable. You can, working together with them. And yeah, we just look at it as this is the best for the patient. It really is, right? We always use that mnemonic, right? But this really is, you're having two people discuss it. Why wouldn't you? Like, why wouldn't you get two opinions? And why is that a bad thing? And yeah, the patients per hour and the RVUs, I mean, everybody does it different, but there's a site out there that's doing it well. So I think there's always someone you can talk to based on how, yeah, you're not
Yeah,
focusing
well,
on that as much.
and that's why every place is unique when you put these mandates in. So there isn't a cookie cutter method.
Correct.
But back to really having a standard or a minimum standard for training before APPs can work in an emergency department, and particularly working solo, but even though we mean not independently entirely, but they're the solo provider at that facility, but working solo, there needs to be a minimum standard in place, and it doesn't exist now. And everyone nods along. Oh, absolutely. That's crazy that you can graduate from an online NP program and do 6 months of shadowing, or graduate from a PA program and not ever have seen, a patient other than, on some shadowing rounds, and then go and work solo in a rural ED with just ACLS, ATLS, and PALS. And despite that, these systems and groups will look at the daunting task of getting to where you guys are now in your process and go, it's too hard, or you have a few meetings, and then the meetings become 6 months and then 12 months apart. You have an index case and everybody meets and goes, oh, that went bad. And then there's a lot of urgency and you do a little bit, and then the whole process, you just can't move to the end. And if someone had put together or set forth a guideline that this is your roadmap to save patient care in rural, I think it would be really helpful, and it would be a resource that these health systems go to have that, have that guide for care, because I don't know that they really know, and I don't know if they're reaching out. So if anyone listening needs that, can they give you a call, Sue?
That is totally fine. You bet. You bet. And that's, to me, it's not fair to the patient. It's not fair to the provider when you're throwing a brand new APP, like you said, an online course, and then they're starting, and that's just not fair, because they're not going to know how to handle things. And a lot of people coming into EDs assume everyone's the same, right? They just assume they've all had the same training, and they're just not aware of the differences. But I think if you get an APP that really loves emergency medicine, does some of these courses, whether it's at your own facility or they take some of the courses out there, Bucatas and some of the others, I think you can get that experience. And, a lot of it, the APPs are really great at getting some of that on their own too. And then that just makes them, a higher up on the list for hiring, because, okay, you've already got this experience. You've been here. Some of them come in with a lot of experience from that respect too. And that's what we want to. So.
Yeah,
but
no,
yes,
it's, well, and many very motivated APPs in a very short period of time can become very educated through some of these programs and hit the ground running, if they're doing some of this after hiring before their first shift, while they're just waiting for credentialing and things. So,
and I think too, like we do skills days, skills labs once or twice a year, and for the docs and the APPs. So we work as a group. So it's not saying, hey, this is only for the docs and this is only for the APPs. And I think keeping that up is good ongoing training for everybody, and yeah, they have their requirements of so many intubations a year. I mean, some of this is just setting things up. It just takes someone to sit down and do it. And so I think if you're an ED director, I think this is just part of your, or chair, I think this is just part of your job, is to kind of get this rolling for your staff.
Mm-hmm. So are you going to volunteer to be on ACEP Council coming up? Am I hearing?
No, I didn't say that. I don't think. I see how this goes. This is how you get these.
Yeah.
We'll talk offline.
There you go. No, it's been a difficult discussion to have, because ACEP is so broadly represented by high volume facilities who don't see the day-to-day in these rural environments and understand the interactions, the lower volumes.
And you want to keep them open. I mean, you just,
Right.
it really is such a help for the people in that area. You know, they don't have to drive 2 hours or an hour to get care. It just really, and it benefits the hub hospital because they're busy already, right?
Right.
Every hub hospital is busy, and you just really need, you need these hospitals to stay open, and you need good care. Yeah.
And many of them, you need their inpatient beds because they
Right.
aren't available at the hub hospital. So you may be doing tele-internal medicine or tele-hospitalist on those that are admitted and stay there. And certainly we saw a lot of that during COVID. But even now in times of peak volumes, there's delays in transfer, and all the more importance of not only good training, but again, that medicine support. So
Support. Yep.
yeah. So this it's been great to connect and talk about this important issue. ACEP has gone a long way and come a long way in creating the environment and the task forces to put together. And what we're seeing is really an evolution within ACEP as well. It's an advocacy organization for emergency physicians and emergency patients. And we're caught up right now with this issue of, look, we've fought to make this a specialty, and we are unique as emergency medicine trained and boarded physicians to do emergency medicine. But at the same time, are we able to take ownership of all EDs when we can't put one of us in each of those EDs? And they exist now, and there's roughly half the EDs in the country that we aren't occupying. And this telemedicine option really gives us an opportunity as emergency medicine trained and boarded physicians to make an enormous impact on a large number of hospitals by just being part of that telemedicine support at a hub hospital. So you can still practice at your high volume facility, which will indulge your interest in why you went into emergency medicine, and at the same time make a huge impact at these lower volume facilities and really take a burden off of these poor APPs that may have been thrust into that environment, less than fully prepared, and really help them to be successful. And to their credit, we want to help them. They want to be helped, and having that collaborative environment is really, the key to success. And
I totally agree, because I think, like I said, we need them, they need us. We all want to work together on this. And I think there's a way to do it, right? We don't have to be way to the right or way to the left in how we, deal out this policy or the guidelines from ACEP. I think where we can work with them and get this done. I really think there's a middle ground.
Yeah,
we're getting there. We
are. And the most recent ACEP recommendations is another step toward the reality and a pragmatic approach to helping manage these rural EDs. So I think
with virtual care, there's just no reason we can't help. I mean, there just isn't, right? I mean, that's one thing COVID did bring forward. Is like, I can video in and see a patient with them, tele-EM we just got to take advantage of that. Yeah. Be there for them.
Yeah.
I agree.
Well, great. Well, thanks so much for being on the podcast and bringing this important issue forward. And we'll look forward to talking again and twisting the arm for council. So.
All right. Well, thank you. Appreciate it.